I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Hi, and welcome back to The Gritty Nurse, an unfiltered conversation about healthcare, nursing, and the intersection of health politics and policy. My name is Amie, and I am The Gritty Nurse. This podcast examines hot topics in healthcare and discusses the changes that we need to see to have a more efficient, robust, and ethical healthcare system that is safe not only for the patients that we see, but also for those who work in the system as well. Sorry, no fluff here, just awesome, compassionate humans and a lot of grit. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit that subscribe button so you never miss out on any real stuff from The Gritty Nurse. On February 9th, 2024, 16-year-old Finley Vander Werken died in an Ontario hospital. Despite being triaged as CTAS level 2, meaning that the patient required urgent care, he waited over 8 hours before being assessed by a doctor. By then, it was too late. Also, in June, a young mother named Ravinder Kaur Sidhu welcomed her third child into the world in Mississauga, Ontario. It should have been a moment of pure joy, but days later, she was gone, another victim of septic shock. Both families believe that if this was caught sooner, it would have allowed them to have returned home. Both stories are a stark, urgent reminder of a silent crisis within the Canadian healthcare system. This isn't a rare disease. Sepsis is a life-threatening medical emergency caused by the body's extreme and out-of-control response to an infection, such as a bacterial or viral or fungal parasitic infection. The immune overreaction damages the body's own tissues and organs, potentially leading to organ failure or septic shock. What is needed is approximately 75,000 cases of sepsis occur in Canada every single year, leading to an estimated 18,000 deaths. That means about 1 in 18 deaths in this country involve sepsis, making it one of the leading causes of death nationally. The cost to our system is staggering, about $1.7 billion annually, but the cost of families like Ravinder's and Finley's is immeasurable. Sepsis is a public health emergency, and yet Canada is one of the few developed nations that still lacks a coordinated national action plan to combat it. Yes, you heard correctly. There is no national plan to combat sepsis. Today, we are asking why. We are speaking with one of the leading researchers calling for immediate change. Fatima Sheikh is a PhD candidate at the McMaster University and is a prominent Canadian researcher focused on health equity and the social determinants of health in relation to sepsis. She's the leading voice in the national call for urgent action on sepsis, a condition in which her and her colleagues have termed a public health emergency. She's a co-author of a forthcoming literature review on sepsis policies, and her research highlights significant and alarming gaps in protocols, training standards, public awareness across the Canada provinces in relation to sepsis. Fatima advocates for a coordinated national action plan that not only standardizes healthcare training, but also explicitly addresses the association between factors such as socioeconomic status, race, and gender, and an overall increased risk of sepsis. Her work emphasizes the critical need to improve public health awareness so that Canadians can recognize sepsis as a life-threatening emergency, paralleling the recognition of conditions like stroke. Welcome, Fatima, to the Gritty Nurse podcast. Just to start off, could you briefly tell us a little bit about yourself, your background, because you are a PhD candidate at McMaster University, and what led you to focus specifically on sepsis in Canada?
Well, thank you so much for having me. I'm really excited to be here. I'm a PhD candidate at McMaster, sort of at the tail end, wrapping up my PhD, and I study the role of social and structural determinants of health and its relation to sepsis, really trying to understand, who is it that gets sepsis, how they fare within our hospitals and our healthcare systems, and some of the upstream policy and public health work we can do to sort of mitigate the burden of sepsis. I really got interested in this work. I think it goes back to my undergraduate studies also at McMaster, where I quickly realized that our health is determined by so many different factors that extend well beyond the four walls of a hospital and our healthcare system, and certainly well beyond our biology. And so I started to take courses in geography and political science and, health and disease from the social sciences perspective. And there was so much to explore. And when you get out into the community, you start to see that at play. And so it's really important for me to think about, sepsis, a condition or a syndrome with such a significant burden in Canada, whether or not these factors were in fact at play and could help us understand, who is becoming septic and how we can better tailor our strategies to reduce that burden.
Yeah, I mean, again, like sepsis has been in the news. We've seen various different folks who have died by sepsis. It is actually becoming a leading cause of death. So, and I think the other piece that I find very interesting is you're looking at it from a different lens. You are looking at it from those social determinant lens. And we don't see that a lot. And one of the things that we have an issue with here in Canada is that we don't collect racialized data, or we don't connect, ethnic based data. What have you seen so far in some of the work that you've done related to the social determinants of health in relation to sepsis?
Yeah, it's a great question, and you highlight a really important point that for a long time in Canada and in our healthcare systems, we haven't collected data on social determinants of health, while our counterparts in countries like the US have been doing this for quite some time.
Right.
That is changing, and there are a lot of efforts to collect this information, recognizing its importance both in the delivery of care and decision-making processes, but also in research. So this work kind of dates back to 2022, where we had done a scoping review of social determinants of health and their relationship to sepsis, just to understand what was out there before we started to engage in our own work. And at the time, we had identified about 20 studies around the globe. They weren't specific to Canada by any means. And most of those studies focused on concepts related to race and socioeconomic status, with a few focusing on concepts like old age and frailty, whether or not an individual had social support, gender, and health behaviors such as smoking. And, across the board, each of these studies demonstrated an association between the social determinant of health and sepsis, with the only variation really occurring in race, where some studies demonstrated an increased risk among marginalized or racialized communities, and some demonstrating the opposite association. And it really speaks to that importance and the nuance of thinking about race. When we're studying race, it's really thinking about racism and the structures that put individuals and communities at increased risk. So that was really our starting point. Since then, we've started to look at it from a Canadian perspective, because none of those 20 studies were actually done in Canada, and really a reflection of our earlier comment about, we don't collect this information. So we then did a retrospective chart review, right, to understand, okay, what is collected in our medical records and what is it that we can understand. And we tried to take a neighborhood perspective, because we often collect postal code, which isn't a perfect measure of social determinants of health, but It is a starting point. And I think it's important to call out here that sepsis is most often conceived of as a critical care issue, or an issue in the hospital, and particularly in our ICU units, and not necessarily something that is potentially influenced by the social determinants of health, or something that is really a community or a public health issue. And I do want to sort of debunk that a little bit in demonstrating that about 80 to 90% of sepsis cases actually start prior to that hospitalization. So they're starting in the community, where, access to care, information, ability to understand that, hey, you know what, I'm not doing well, I really need to see a healthcare provider. So going back to that retrospective chart review, we kind of looked at areas that have previously been demonstrated to be marginalized communities, or communities that are socioeconomically disadvantaged. And what we found, or what we demonstrated, was that among these neighborhoods, individuals are more likely to come into our hospital and become septic, and more likely to die of sepsis as well. And that risk is about 2 times more likely approximately, right? So it really demonstrates this interplay between those individual level social determinants of health. So things like, how much you make, your race, your ethnicity, your education level, but it also speaks to those environmental factors, your community, what you have access to, whether it's, green space, the proportion of primary care physicians in your area, your ability to access healthy food and nutrition. So when we talk about social determinants of health, I think we often fall into this deficit-based perspective where we're saying, XYZ communities are at increased risk or XYZ individuals are at increased risk. And we tend to avoid talking about why those communities, why those individuals are actually put at risk, right? Our systems weren't designed for these individuals. And so it's really an opportunity to collect the information so we can understand the mechanisms that put individuals at risk for something as severe as sepsis. So then we have opportunities for targeted solutions, whether that be from a public health or a policy perspective, or, in the clinical care and decision-making perspective.
When I think about the cases that I've ever encountered in quality of sepsis, or even just looking at some of the most recent cases that I've seen in the news, I would say that it's also, there is no age. It doesn't discriminate, right? It doesn't look and say, okay, sepsis is particularly only a disease that is seen in elderly people. We've seen it happen in pregnant folks. We've seen it happen in a variety of different individuals. And I think one of the things that you had mentioned is you did say that it's a public health emergency. Why do you feel this way? And what is it that you think people need to know? The point that you pulled out was it is seen it starts in the community. So what is it that people need to know? What is it that I need to look for? Is it something that is easily treated? So again, just backing it up, because I've now put in like 3 questions. Why would you consider it a public health emergency? And what would you want community folks to know about how they might identify sepsis in the community?
It's a great question and a great series of questions and an important piece to sort of think about, right? I think why it's a public health issue is because, it really starts in the community. I'll give you a quick parallel here. So when we think about the COVID-19 pandemic, right? I know no one wants to go back there, but it's important for us to sort of reflect on
100%.
A little bit, right? The difference here was that this was considered a public health issue. There was vaccination campaigns, there was strategies that were put in place to ensure that everyone was vaccinated, that everyone was educated about when to go to urgent care versus emergency care versus their family physician. Folks were taught about, when to stay home versus when it was okay to go to work, who you could socialize with, who you couldn't socialize with. And sort of the end of COVID-19, the individuals that died of COVID-19 were really dying of sepsis by definition, right?
Yes.
And so now we have this condition or this syndrome that is impacting millions of people around the world and in Canada. And there seems to be a lack of emphasis on this being a public health emergency or a healthcare emergency. Same thing goes, another example I often give is about stroke. Right? Whether you know all of the signs or symptoms of a stroke, if someone is experiencing those, you can identify, okay, something is wrong and I need to call 911 or I need to get this individual to a hospital immediately. When you get to the hospital, the healthcare professionals know, okay, time is of the essence. This person is experiencing a stroke, and there's a clear pathway for escalating care so that that individual is cared for to the best of our ability. There is no equivalent for sepsis. And so, it's a public health emergency because it's something that, to your point, can affect anyone at any time point. And, I think that's also why we talk a lot about some of those upstream public health and policy interventions, because it's something that, is a downstream impact of, for example, a paper cut on your finger, an infection, or, pneumonia, something like that. And it can impact anyone. And so we really need to think about what is it that healthcare professionals need to be aware of to be able to detect the signs and symptoms. What is it the public needs to know, right? We were talking about those signs and symptoms of stroke, but, when do you need to know that, okay, I need to get to a healthcare facility? What are those signs and symptoms? And, I think it really boils down to building that awareness and the education in a way that is culturally responsive, right? So it's not just about sharing information. If the information isn't getting to the people who are most most at risk, then that information is ineffective. That's really why I think it's so important to think about, automating some of this work in that everyone is forced to think about, could it be sepsis, right? Ensuring that is something that is front of mind for everyone.
Yeah, no, I think that dovetails really well into this kind of next question that I have, because I know that there's significant gaps, particularly in policy. So like you mentioned, stroke. So the hospital system has something called a code stroke. It's even done in conjunction with the community. So for example, even paramedics and various other folks know that if it's a code stroke, these are the things that need to be done. So they're already activating some of that work within the community. And then, there's acronyms like FAST and various different things that people can remember to recognize those signs and symptoms. But I agree with you. I think it is a policy gap issue where we are not recognizing and identifying those early interventions and actually doing something in the community. So one of the things that you highlighted are that there are these gaps. From your perspective, what do you think is the most alarming gap that you might have noticed that's leading and impacting the care delivery right now?
Yeah, so I'll sort of mention two things. One, we had written a piece about reducing the burden of preventable deaths from sepsis in Canada and why we need sort of a national sepsis action plan. And we talk about how policies typically in Canada are reactive. So some sort of tragedy occurs, and then we sort of scramble to put forth a policy. And, the food safety policies to prevent sepsis in US and Canada following some of those sepsis-related deaths from foodborne pathogens is a good example. The new long-term care standards to prevent sepsis following deaths due to COVID-19, another example. And some of the work that we've seen in other jurisdictions, for example, in the US around state-level policies, were put in place following the death of a child and have done, subsequently gone on to demonstrate their effectiveness. But it's really important for us to ensure that we're not reacting to tragedies, but we're really thinking from a proactive standpoint and ensuring that across the provinces and territories in Canada, we have some work put in place. And so we really need to think about including sepsis prevention, diagnosis, and treatment in community and healthcare settings, to really think about implementation of standards for diagnosing and managing sepsis in healthcare, in health emergencies. I talked a little bit about, that public awareness piece, and thinking about developing standards for all health professionals to recognize and appropriately treat sepsis early. And I'm not just talking about physicians and nurses, but, right from the beginning, from our primary care physicians who know when to escalate care, our EMS staff who are potentially bringing in these individuals, and everyone across the continuum of care. And then really thinking about the place for innovative research to address sepsis across the lifespan, right? Because we're talking about before and beyond the hospital, so including in that recovery journey. To sort of inform a lot of our thinking on this work, we did do a jurisdictional policy review looking at exactly sepsis policies, guidelines, and health professional training standards here in Canada. And the intent there was we need to figure out what exists in Canada and what we can leverage to support this work. This review is currently under review at the Canadian Journal of Anesthesia, so can't reveal too many results, but across the board, what we demonstrate is that, in the absence of a national strategy, we see gaps across our provinces and territories, right? And so there is a role for, the federal government to come forward and work on a national strategy so that it's clear what provinces and territories need to include in their guidelines and health professional training standards and, in terms of sepsis policies, so that it's something that is built into our systems to really be thinking about sepsis.
Yeah, you would kind of think this is a no-brainer, really, right? I don't mean to seem like stark like that, but it's kind of like this. Why don't we have national standards? Healthcare is this really weird world where we do things in silos. Yes, we have different provinces and territories, but like I said, sepsis doesn't discriminate. And you draw those parallels to stroke. So it just begs to question, why don't we have these national standards and guidelines that we can all use to prevent this? And some of the stats I saw some stats is like 1 in 8. That's up there with, with leading causes of death. I know we talked a little bit about the social determinants of health, but one of the things that I used to encounter when I worked in quality was we were looking at folks like the migrant population working within farming and that type of industry. I also did some research into looking at, folks that are precariously housed. And again, my concern is those are the huge gaps that we tend to see, right? The fallout from, these various different communities. And of course, these people tend to be racialized. It was really concerning to me. And again, like you mentioned, COVID-19 really kind of pulled back the veil on showing, for example, those, like you're using postal codes. And I think it did pull back the veil and saying there's these pockets and these communities that we're really, really failing. So are there any specific target communities right now from a social determinants of health standpoint that you're looking at from a national standpoint? Or is it kind of like, okay, we have the starting point where we're looking at, addresses, postal codes. Where is the research kind of heading to right at this kind of moment?
Yeah, it's an excellent question, and I think a well-taken point for sure. I think different from a lot of other healthcare challenges is that for sepsis, we kind of know what needs to happen, right? This isn't a situation where we're grappling with, okay, would this work, would this not work? We have a growing body of evidence from around the world, on the positive impact of policies, guidelines, and integration in health professional training standards. Other jurisdictions have implemented sepsis national action plans and demonstrated, a reduction in morbidity and mortality and cost savings, both for the individual and for our healthcare systems. So we know what to do, and we have the evidence to do that. I think from my perspective, when we're thinking about equity, most of those national action plans that we've seen in other jurisdictions haven't necessarily baked in equity. That's not to say they're not considered, but I think we're really designing from a place of centering equity. So no one particular population that I want to call out at this moment, but really ensuring that this isn't a one-size-fits-all approach, that we are considering populations that are at increased risk because of the systems and structures that we live in and have been built around, and really ensuring that they are considered appropriately, they're not falling through the cracks, and that this plan is designed accordingly. So to do that, we're really making sure that we have health system decision makers, researchers, quality professionals, people across the continuum of care working collaboratively across those sectors to avoid that siloing approach, to ensure that what we design can then subsequently be implemented and then appropriately evaluated. I think the other piece that's key to this is that we're starting to collect social determinants of health data. We've written about the challenges of collecting race-based data, as have many others in the Canadian context. But I think a lot of our health systems have moved towards, as challenging as this process is, and needing to work directly with patients and families and our providers to ensure we're collecting equitably. At the end of the day, we need to collect this information so that we can understand what specifically the disparities are, what populations are, disproportionately impacted, so that we can design around them. And we know, the evidence demonstrates that when we design for the individuals at the margins, it actually has a collective benefit across populations. So really, for this to be a true Canadian national approach, designing for our equity denied populations, the populations that have been put at increased risk, is going to be for the benefit of everyone.
Yeah, no, I think this also speaks to these various different layers, right? So we have our researchers, our policy designers, and we have the community. One of the things that I see time and time again, and I know hospitals are trying to do a little bit of a better job of this, is how do we bring the community into this work? So again, we are great at making policies, but not so great as bringing, those patients and families that might have been affected by sepsis. How do you intermarry the two? And again, I think we've touched on this where we're talking about, there's the research world and then there's the implementation world, but also how do we bring in here's my community voice world, here's my lived experience world? How do we make sure that the communities that are hardest hit by sepsis, how do we ensure that, with the research and policy and with implementation, that we don't miss out on the important voice of the community or the patient?
It's such an important question. And, it's challenging because we haven't done it for a long time and we're just starting to learn what true partnership looks like, right? A lot of our research is investigator driven. It's not, patient and family and community partner driven. But I do see a world in which that is going to be the norm, and one that I hope to be a partner in, right? The kind of researcher that is supporting questions that are directly informed by communities, and really you're the researcher is the ally or the tool in supporting some of that work. So, perhaps, aspirational, but I think that's where we need to get to. And you're totally correct in that, oftentimes our implementers are, employed to implement, and our researchers are employed to sort of do the evaluation. And these two roles aren't talking to each other. It's why we see that 17-year sort of evidence to implementation gap. And I think it's a function of how we train individuals. It's also a function of, the sometimes necessary siloing, but also the problematic siloing. I will say for the Sepsis National Action Plan and a lot of work that I've been fortunate to be a part of, patient and family partners are at the center of that work. And when I think about a Sepsis National Action Plan, when I think about sepsis policies, a lot of that work across the globe has been driven by patient stories.
Right.
Whether it's, stories of like, I went to a healthcare facility, I was able to get the care I needed, or, sort of the opposite in some of those tragic stories, they are ultimately driving those conversations. And I think, my role in this work is really to listen, to learn, and to make sure that we're appropriately engaging. And I think when it comes to the community perspectives, we often get challenged with, who is the community and how do you, become and engage and become part of those communities, so on and so forth. But I often argue, and I give the parallel, like all of us as individuals are part of community. Whether it's whether it's the people you play pickleball with in the evenings, or a religious affiliation, or your kids' school group, we're all part of communities. And I find that in research and in clinical care, we tend to see ourselves as outcasts or separate from these communities. And It's just sort of leaning into that discomfort of almost democratizing the knowledge and ensuring that we're engaging and disseminating. And I think we're just stronger for doing that work. And so when I'm thinking about some of the national work that's forthcoming and some of the work that we'll do to bridge the gaps in sepsis care and policies, in terms of, in addition to engaging and centering equity, it's really going to be thinking about and ensuring that we're talking to the right people, that they have a voice at the table, and that those voices are heard and sort of implemented.
Yeah, no, I think that's a powerful way to do research, to implement, to make sure that those voices are heard. Like I know there's a family that I've been talking to. I'll be talking about them probably just down the line, talking about Finley's Law, and just the fact that, it's so important that we take those stories and we do something with them. I think that's sometimes in healthcare, we hear the stories and we're like, that was painful, and we do nothing. So I'm always a proponent of like, stories are powerful. Stories are what make change, but we also need to make sure that we act on those stories and that we do something. So, and I'm more than confident that your office will be doing some of this great work as well. Last but not least, is there room for AI to help with sepsis?
What a very, very timely conversation. So I appreciate you asking. I would say certainly. Right. I think AI is a tool and something that all of us need to be sort of thinking about proactively in terms of its use. What I will say and what I will caution, as an equity practitioner, as someone who's thinking about equity in research, and particularly when we think about who's included in research and potentially who's missing, going back to that idea of, collecting social determinants of health versus not collecting those determinants of health, is really ensuring that any use of AI is really grounded and we're critical of what we're seeing, so as not to perpetuate existing biases, right? And in saying that, we often think about how do we augment these tools to support equity-informed decision-making. So, for example, one of the things that we talk a lot about, and something that, I'm quite interested in, and it's a half-baked idea at this stage, but it's really thinking about, in the same way that we look at biological determinants and we think about risk prediction models that are sometimes informed or driven by AI that can certainly leverage larger data sets, is there a way to then embed equity in those social determinants of health in the same way that we do the biologic determinants, because we know that they increase risk, or that they can help us understand risk. So I think there's absolutely a time and place for AI. And I think we're at a place where we need to be cautious about its use, particularly in clinical care and its relation to research. So it's not to say, we shouldn't be using it. It's we should be using it. And we need to think about, those equity considerations and ensuring that, our data sets are reflective. I think the perhaps easiest way to move about this is really thinking about, how do we design research studies such that, when they're implemented in some of these models, when they're considered in AI, that they're not perpetuating those biases. And it really comes down to appropriate data collection, whether it's the social determinants of health or not. And it's also thinking about patient-important endpoints, right? Oftentimes we're thinking about things like mortality or morbidities. And, the conversations we're hearing from our patient partners is like, can I get back to my job?
Right.
Am I able to run errands with my kids and take them to sports? Am I able to return to normal, right? And those are things that are important. So to your earlier point, right, it's ensuring that these individuals are at the table, having these conversations, you're thoughtfully considering those perspectives in the design. And then I have confidence that we'll be able to appropriately use AI in the future of sepsis.
Yeah, I'm all for baby steps because the conversations, like, we can't get away from the conversation about AI. Like, it's coming. But the thing is, I agree with you. Equity has to be baked in because we've seen where in systems where they do use AI, where again, it can be faulty, it can be discriminative. I've seen, for example, I did an episode on mental health and folks using AI models to actually receive treatment and how it showed bias towards, folks that were either were alcohol consumers or had schizophrenia. So we have to be very, very careful when we're talking about using machine learning, particularly in healthcare, because we can see those disparities. Last question. Is there one message that you want the healthcare policymakers, hospital administrators, or the public to take away in relation to some of the research and work that you're doing on sepsis? What might that be?
Yeah, I think honestly, my key message is sepsis is a medical emergency and we need to treat it as such. So that means everything from ensuring people in the community are equipped to understand the signs and symptoms and know what to do with that information and access the right level of care. And for our healthcare professionals, ensuring that, they are appropriately trained to detect those signs and symptoms and treat it quickly and rapidly. We have a lot of emerging issues when I think about, appropriate antimicrobial stewardship and its relation to sepsis and antibiotic prescriptions, integration of AI and new technologies. But at the end of the day, sepsis is a medical emergency. And I think providing, ensuring that it's treated as such will get us where we need to go. And I think at the end of the day, those partnerships, whether it's, with our policymakers, our clinicians and our frontline staff, our patient and family partners in our communities, and it's really breaking those silos to ensure that we're thinking about this from the outset together in a way that is equity informed and data driven. So ultimately, I'm confident that we'll get to a place where, we are seeing a national strategy and we're seeing equity centered. But ultimately, it's going to take a collective effort. And I think perhaps the last message is that, sepsis is something that everyone should be thinking about.
Yeah. And maybe just before we go, what in the community, what should patients and families, friends, allies be looking for in relation to sepsis, just quickly before we go?
Yeah, I think it's really, when your signs and symptoms are escalating, someone's not sort of feeling well, knowing when to sort of escalate that care is ultimately the most important piece here.
Yeah. Okay. So thank you so much, Fatima, for coming on the Greeners podcast. A great conversation. And I'm sure that we'll have to be touching base to see kind of where the research is leading and where we are on moving it. And I just think about who are the people that in policy that I need to kind of knock on their door. I know we have a new federal minister of health. I know various different key players in Ontario. And I think we do need to make it top of mind. So just thinking about who are the different people that we can kind of draw in and bring and raise more awareness about that this is a national and public health emergency. So again, thank you so much for coming on the Greeners podcast. Is there anything that we might have missed?
I don't think so. Just thank you for having me. This is a great conversation, and I hope one that we'll continue to have, across this country and with different people because it's an important one.
Yeah, no, I'm looking forward to seeing the work that you're going to be doing. And I do feel confident too that we have to see change. Again, we have to move the needle, right? I think that we can't keep seeing these headlines coming through and seeing that, people are dying by sepsis and just not having a national standard, not having a national approach. It's ludicrous. Maybe someone out there is listening going, oh, we don't have that. and we can make some change. So again, thank you for coming on the Gritty Nurse podcast. We'll have more conversations about sepsis and how we can bring and facilitate change in not just in Ontario, but across Canada. And yeah, we gotta get this research thing going, right?
Yeah.
Data collection going.
There you go. I totally agree. Thanks again so much for having me.
Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much and stay tuned until next time. Stay gritty.